Welcome. Today we are covering calcifying odontogenic cyst or COC. Welcome to our new video. Recently we have discussed about AOT and amyloblastoma. So today we are going to discuss about COC, also known as calcifying odontogenic cyst. So firstly, this is a rare odontogenic lesion that features ghost cells and is frequently tested in exam for diagnosis and histology. So we have to go in there to clear our concepts about this. Moving forward, now we have to first know why this topic matters. So the reason why you should focus on COC is it appears often in oral path MCQs and vivas. It can be confused with odontoma or ameloblastoma. Its unique histology, especially ghost cells, makes it high yield for exam. Treatment depends on whether it is cystic or solid. So we have to remember examiners focus on classification and histology. Now coming to the definition and overview of COC. So, COC is a rare, well-circumscribed odontogenic lesion. It may be cystic or solid and is characterized by ghost cells and calcifications. The key point we have to remember, it is no longer considered purely a cyst, which is important for your exam questions. Please try and note it down that it is not considered purely a cyst. Okay, that's the definition of our topic. Now, moving forward to the etiology or origin. So, COC, also known as calcifying odontogenic cyst, arises from odontogenic epithelium. It shares histologic features with ameloblastoma. So, this is important. It may present as a cystic form, which we call COC, a solid form called odontogenic ghost cell tumor. So, this is the point to remember here. Sometimes it is associated with an odontoma. The change in classification is, often tested in exams. So you have to remember this. Now, coming to the pathophysiology or mechanism how it works is the development of COC happens in steps. The first step is proliferation of odontogenic epithelium. After that, formation of an ameloblastoma-like epithelial lining is seen that leads to the development of ghost cells, which are eosinophilic cells without nuclei. So this is basically the definition of those ghost cells I was discussing about. Now, we see that the calcification form within ghost cells and surrounding connective tissue. You can visualize this like the Bell stage of enamel organ ghost cells classification. Now, we will see the clinical features. Clinically, it can occur at any age, but most commonly in the second decade of the life, usually anterior to the first molar. And what is also seen here is intraosseous lesions expand the cortical plates, while extraosseous lesions are localized swellings. Pain is usually absent. This is a silent but expansile lesion. You have to remember this key point that it is basically, and here are the pictures that you can see what is basically happening in this disease. Now, for the diagnosis or key findings, we have to do two things. As we know, first we have to go for a radiograph. So firstly, we have to know that COC usually appears as a well-defined unilocular radiolucency. It often contains flecks or nodules of radiopacity. In younger patients, it may mimic developing odontoma or ameloblastic fibrodontoma. So this is seen on your X-rays. Now moving to the histology, ameloblastoma-like epithelium with palisaded basal cells is seen on your histo, while stellate reticulum-like layer. Host cells are the one they are seen. They are anucleate eosinophilic cells, as I have told you. their definition, and spherical and diffuse calcification can be seen here. Remember, core cells are the diagnostic anchor for your exam. So go where you see core cells, you may you may consider it as a COC. Now coming to the management and treatment. Treatment depend upon lesion location and type. So peripheral lesion, it just requires a simple excision. Central lesions require an enucleation, while solid form, usually curettage, rarely if aggressive, block resection. The recurrence is uncommon, which is important for your exam points. So now we got a clinical scenario, but before moving to that, you have to consider that the common mistakes or exam traps you can just find during your exam. Watch out for these pitfalls, like calling it only a cyst. That is not a true thing. And missing ghost cells on histology. That is also a blunder you can make. Confusing it with odontoma or ameloblastoma. Or ignoring the solid, potentially aggressive variant of this disease. Ghost cells are the key diagnostic clue. So please remember this. Now we got a clinical scenario. Here's a short case. A 17-year-old patient present with painless swelling in the inferior mandible. Radiograph shows a unilocular radiolucency with scattered radiopaque flakes. Histology reveals core cells and calcification. So what could be the most likely diagnosis? Obviously, it could be a calcifying or odontogenic cyst. Okay, as I have told that ghost cells are seen here, anterior mandible, unilocular radiolucency, radiopaque flakes, these were the key findings. Now coming to the key takeaways, to summarize, what we can say that COC is a rare odontogenic lesion with ghost cells. It can be cystic or solid. Conservative treatment is usually sufficient. So this is all about COC, and the reference we use is Neville Contemporary Book, and I just wanna ask you guys to subscribe my channel. So it is a motivation for me to make more videos like this, and it could help you. And please don't forget to like or comment. If you want any other help, you can just ask me. I'm here. So some quick questions. I would say that what I'm gonna just give you a quick recap with some question that which histologic features diagnostic of COC. These those are the ghost cells. And why is COC no longer calcified purely as a cyst? Because it can be solid, and most commonly affected age is the second decade, and the treatment of choice for central COC is enucleation. I hope this will help you in any of your exams. If it does, please subscribe. As I have told you, I'm new to this, and it could just keep motivating me. Thank you. If you have watched the video, just kindly subscribe the video. Thank you very much.